A very big hello to all my dear students. Welcome to the alphabetical series in your favorite channel, You and I with Dr. Ruchi Rai. So, which alphabet today? We will be talking about E. So, what are we going to, can you guess what are we going to discuss in E today? Now you know it, right? So, we are going to talk about esotropia. What do you see here? What I see is a child with the right eye esotropia, right. So, if let us first look at this, the right eye is esotropic, that means there is a convergent squint, and when he is wearing the specs, you can see the central reflex in both the eyes is straight now. So, which is corrected by specs. What are we talking about? Yes, so we will be talking today about esotropia, that is accommodative esotropia, right. So, we divide esotropia. When you say accommodative, so because it is a very broad topic, I cannot take the whole thing. So, we are being very specific here. So, we will talk about accommodate. This is mainly the question that is asked in your exam. But to give you some background so that you know how to really think about it. So, we divide squint into manifest and latent very quickly, right. So, manifest squint is called tropias and latent are phorias. When you say phoria, it can be esophoria means convergent, exo is divergent and hyper means one eye is up, one eye is down. So, it is a protocol to mention the eye which is up, right. We know this? Okay. We talk about tropia. Again, tropia can be classified as esotropia, exotropia and hypertropia. Another way of classifying is concomitant or inconcomitant, right. So, if you remember very quickly, concomitant means the degree of the squint is equal in all gazes, primary deviation is equal to secondary deviation. So, maybe in some next video we can go into too much details about all this, right. But we come back to another important thing, when you say inconcomitant, it is just the opposite, okay. So, paralytic squints, restrictive squints, they are inconcomitant, where the degree of the squint varies with the gaze, right. And in paralytic squint, especially we should remember that secondary deviation is more than primary deviation. Okay. We come back to esotropia now, that is a manifest squint where the eye is convergent, right. So, esotropia can be non-accommodative or accommodative. So, when you say non-accommodative, there can be different factors like stress induced and so on, but what we have to learn major is accommodative esotropia. Now, you got the background. So, now we can move further. Accommodative means when we say accommodative esotropia, this is the case of accommodative esotropia, we are talking about that this convergent squint is actually happening due to too much exercising of what? Accommodation reflex. So, we come back to accommodation reflex. So, this is due to excessive accommodation, due to the accommodation reflex, this is mediated and the squint is happening. What is accommodation reflex or near reflex? When I am looking from far to near, three things are happening in my eyes: convergence, meiosis, accommodation. तीन चीजें हो रही है ना, convergence, meiosis and accommodation, right. So, it is mainly when there is too much of accommodation that actually leads to convergent squint, right, can lead to a convergent squint. So, when this accommodation is due to the exertion of this esotropia is due to this accommodation, we call it accommodative esotropia, as simple as this. ठीक है, clear हूँ मैं? Okay, we can divide accommodative esotropia जो कि accommodation reflex के वजह से we can divide it as either it is refractive type, okay, or it is non-refractive type, or it is mixed type. Chal, it is very simple and interesting. When you say refractive, which refractive error we are talking about? Uncorrected hypermetropia. So, actually this is what you saw in this patient. When the hypermetropia is uncorrected, okay, think with me, I am thinking loud with you all. Hypermetropia is what? Less power in the eye, correct? When you are not using specs, your eye tries to compensate this less power. How can the eye increase the power? We have learnt in our A alphabet about accommodation. So, when the accommodation is exerted, there will be more power, power of the eye increases. Okay? So, when the power of the eye is increasing, what next happens is the hyper, why, okay, so the due to the exertion of the accommodation is the only way through which the eye can actually increase its power. That is what I wanted to say, sorry, right. तो क्या होता है, if hypermetropia is not corrected, too much of accommodation is exerted. When too much of accommodation is exerted, because all these three go as a part of reflex, there is convergence. Now I am clear? क्या बोला मैंने? When there is an uncorrected hypermetropia, to compensate for that less power, more accommodation is exerted. When more accommodation is exerted as a part of reflex where convergence, meiosis, accommodation go together, you get a convergent squint. So, in this case, what is the treatment? Treatment would be just correct the hypermetropia. So, that is what you saw here. When I did a refraction and gave specs to this child, the eyes became straight and everybody is happy, no surgery is needed. What is non-refractive? There is no hypermetropia, but still you are seeing an accommodative reflex. This is accommodative esotropia when there is high AC by A ratio. Okay. What is AC by A ratio? What is the accommodative convergence per accommodation? Right. So, what is accommodative convergence per accommodation? So, some children, they like a motor imbalance, are born with high AC by A ratio, means even if there is a little accommodation exerted, there will be convergence of squint, convergence of the eyes or convergence squint. You got it? So, AC by A will be how much convergence in prism diopters per how much diopter of accommodation. This is how we depict AC by A ratio. ठीक है. So, around between 3 to 5 it is considered normal, 3.54 it is considered normal, but when it is a high AC by A ratio, then it means that this child is very prone for convergent squint. अब क्या करोगे? There is no hypermetropia to correct, so refraction is not the treatment. So, what will you do next? So, in this case, I want to relax the accommodation. How can I relax the accommodation? First of all, I can go for some use of near glasses. Give the glasses so that the eye is not exerting accommodation. Secondly, we can go for pilocarpine. What is this doing? See, this accommodation is it is the central reflex, right? Now, when you give pilocarpine from outside, it is taking care of the meiosis and accommodation. So, it is a peripheral effect. So, centrally the impulse is not going to be going for accommodation, because pilocarpine you have taken care and it is causing already the accommodation and meiosis. जब central impulse नहीं जाएगा, what will happen? This convergence of convergence of eyes will not take place. ठीक है, समझ आया? So, this is how we manage a non-refractive. And mixed is very simple, you know, it can be both hypermetropia also as well as high AC by A ratio. I think it's good, right? Okay. So, this was a quick recap on accommodative esotropia. That was for E, alphabet E. Okay? So, in this case, this is a refractive accommodative esotropia. We can be more specific. This is refractive type because after giving specs, we are able to treat his esotropia. Okay? High uncorrected high hypermetropia, non-refractive high AC by A ratio, right? And third is mixed type. Hope I was clear. We next talk about a quick discussion on the question. A 3-year-old child presents with a right convergent squint of 6 months duration. What is the appropriate management? Whenever there is any squint, what is the sequence? Should always be refraction, then check for any amblyopia and go for occlusion therapy, and then comes the surgery. This sequence should be absolutely very clear. So, our answer will be proper refractive correction first, then amblyopia therapy followed by surgical. This is asked in your exam many times. So, please remember this: refraction, occlusion, surgery. Okay? Refraction, occlusion, surgery. Of course, if needed. If the child is not amblyopic, we are not doing anything. Hope you enjoyed this discussion. Thank you so much. Stay blessed and keep smiling.